Hello and good day to everybody, and thank you for the invitation. So today, my topic will be how about treating aneurysms, especially when should you not treat aneurysms? Um, First of all, my conflicts of interest. So I start with the conclusions. Conclusion is that I believe that small incidental aneurysms are not a major threat for people's lives. Of course, there is a definite amount of uncertainty, but one of the secrets in life is to learn to live with uncertainty. I don't treat small incidental aneurysms. No follow-ups, no screening, forget your aneurysm. But what is small? So what is my number? More or less, I would treat all aneurysms which are larger than 10 millimeters, and I would not treat aneurysms which are smaller than 8 millimeter. But is that the only thing? Only size matters? Probably not. But so far, we don't have proofs of that yet. Size is a good start anyway. I also want to stress that I hope we all agree at last that aneurysms, for the most part, are not congenital and are not genetically determined, which is something that most patients think, but they think it's like that because most doctors tell them that that's the point. So there is one question. The aneurysm that ruptures today was a small incidental aneurysm yesterday? I see the aneurysm as a wound, as a dissection in the arterial wall that appears as an accident at any time in adult life. And so when it appears, it is painful, and that's why often we have a headache and a very acute, severe headache, which we call the sentinel headache, which might correspond to a small bleeding, but most of the time there is no bleeding. There is just the dissection, which is very painful. And then the aneurysm, it grows fast to a certain size. It could be minutes, it could be hours, it could be days, but it's really fast. And so it's very unstable and it's prone to acutely rupture. But if it doesn't rupture, what happens? It stops its growth and it's prone to progressive healing like any wound in our body. And so it remains sleeping for the rest of life. So why I do not treat small incidental aneurysm? Obviously, because I think that the trade-off between treatment and natural history is unfavorable. The risk of treatment, which of course we talk about mortality and permanent morbidity, neurological risk, is 3% in the most optimistic disclosures. But I believe that it's probably more like 5% or more. If we look at the risk of treatment of unruptured aneurysm in trials and registries, I'm sorry, this is not unruptured. This is also ruptured, but a quota of these groups are also unruptured. And anyway, the risk of treatment is pretty high. Only probably in the Korean group, it's around 5%, but all the others are really in two figures. And if you look at an editorial which was written in 2011 by Molyneux, they look back at the rate of discharges to non-home rehabilitation facilities in the group of aneurysms which were surgically clipped, and 1 in 7 did not go home. So that's approximately 14%. And 1 in 20 after coiling, which is approximately 5%. But anyway, it's much higher than we normally think. So how does that risk compare to natural history, the risk of treatment? Well, what is the risk of natural history? It's difficult to say, of course, because we lack data. First of all, what is the prevalence of small incidental aneurysms in the general population? Oh, prevalence. Well, how can you know? The better you look, the more you find, of course, because some aneurysms are very small. And of improving our instruments, we will find more and more aneurysms. If you look at the literature, it goes from 3.6% to up to 10%. And already in 1998, Rinkel thought it would be up to 6%. So that was 1998, when we did not have all the possible diagnostic measures that we have today. So the literature is from 1 to 10%. On my guess, it's that it's at least 6 to 8%, which means that 1 every 12, 15 people has an intracranial aneurysm. So in a bus, there are 3 or 4, in an airplane, 20 to 30, in a ferry boat, 100 to 200, and in a football stadium, there are thousands of people harboring an aneurysm. And we keep saying that if you have an aneurysm, you should not do big efforts. You should not have your blood pressure going up. But in fact, in a gym every day, there are probably 50 to 100 people with an aneurysm, giving birth every day, scuba diving every summer, bungee jumping, all situations where we don't see that many aneurysm rupture. Having sex any minute? Let's do some calculations. In Italy, we say that the incidence of subarachnoid hemorrhage is more or less 8 over 100,000 people, which is typical of all Western countries, more or less. And so let's say that the frequency of aneurysm in the overall population is about 8%, just to make calculations simpler. That would say 8,000 over 100,000. So the risk of rupture is 1 over 1,000 per year. And if the risk of treatment is 3%, that's 30 over 1,000. And so it's the risk of rupture over 30 years. But we said that probably the risk of treatment is much higher. And if 5%, then that's the risk of rupture over 50 years. That's a very long time. Am I right? Well, maybe not. The typical objection is most of the aneurysms that cause subarachnoid hemorrhage are small. So how can you say that small incidental aneurysms carry a low risk? Well, it's simple. Why? Because one possibility is that the great majority of the aneurysms are small. So also the majority of those that rarely rupture are small. Let's say that most car accidents are due to excessive speed. So you would assume that you would have more accidents for the fastest cars. But in fact, we have many more accidents for slower cars. So why? Well, just because of their prevalence. But if the aneurysms that we incidentally discover do not rupture, where are those that one day will rupture? Maybe they are different aneurysms for growing speed or modalities. Maybe they are not yet there. The possible scenario, as I already told you, is that an aneurysm is born, then that's when you have pain. It grows rapidly in hours or days, and either it finally ruptures, and then you have a subarachnoid hemorrhage, or it stabilizes, and then you have an incidental aneurysm. So the small incidental aneurysm is a scar. It is an aneurysm that did not rupture when it had a chance to rupture when it was born. Now it has healed. It will not rupture anymore, more or less. So do you think this is a nice new revolutionary idea? On the contrary, already in 1987, Weavers and Sund, great neurosurgeon, wrote on Journal of Neurosurgery that the data that we have accumulating in the study suggests that aneurysms develop over a relatively short time. And so either ruptures or the walls undergo a process of compensatory hardening. And even if you have a small aneurysm, you may have an intracranial bleeding for other causes. So what bleeds? A study, when they followed up intracranial aneurysm unruptured with CT and MR, there were 93 patients. 2 of these 93 had a subarachnoid hemorrhage. So that was 2.2% in 2 years. That's a lot. But in fact, one was from an aneurysm at the clip site from a previous operation that ruptured. So, and that was without enlargement. That's also interesting. And one from a newly developed dissecting aneurysm, so a de novo aneurysm. And 0 from the small aneurysm that was being followed. So you follow an aneurysm, but in fact, what bleeds is a different thing. And in the long-term follow-up of the ISA trial, which was a follow-up for a minimum of 6 years and a maximum of 14 years, 16,000 and more person year follow-up between coiled and clipped aneurysm. So were there rebleeds? Of course. 24 were the rebleeds. 13 were from the treated aneurysm. So it was treated, but it was not treated, obviously, or at least it was not cured. That also has to be considered. But 10 from another aneurysm. 4 of these 10 were already known, but 6 were from a new de novo aneurysm. So the bleeding comes not from the aneurysm that you're following, but from a different aneurysm which is not there. So if most of the ruptured aneurysms are de novo aneurysms, how functional can be our prevention? A hemorrhage in the follow-up may be due to the rupture not of the previously known incidental aneurysm, but of a newly formed one. This point may have, of course, a devastating effect on the desired prevention of a subarachnoid hemorrhage. Why? Well, because the aneurysm treated today in the desire to prevent a future hemorrhage is not the one that will rupture in the future, because the latter is not even born yet. Let's take 1,000 people with an incidental aneurysm and treat them this year. Next year, we will have 50 people who have serious morbidity or are dead because of the treatment. And we have 950 people who will have to undergo a more or less intensive series of examination in the follow-up, who have to see doctors, who are a little bit uncertain about their future, who have to be perhaps retreated. And of course, who may still have a bleeding from the same or from a de novo aneurysm. Now let's take the same 1,000 people with an incidental aneurysm and not treat them this year, and tell them that it's perfectly normal to have an aneurysm in the head. The risk of rupture is minimal, comparable to a car accident. They should not worry. They should just forget the aneurysm. Next year, we will have 1-2 persons who have a serious morbidity or are dead because of the rupture of the aneurysm. But we will have 988 and 199 people who will have returned to their normal life. And we will achieve parity with the other group in about 30 to 50 years. And that's parity. So we will need further time to realize a substantial gain of the treatment. That's a wonderful gain in anxiety, worries, family disturbances, personal expenses, healthcare system expenses. And of course, it might be that in the future years, we will have a better treatment, maybe a pill. Of course, by not treating small incidental aneurysms, some people will not be happy, but I have the feeling that they will not be the patients. So the conclusions for this part is that what should we tell the people who come with a small incidental aneurysm? We should start by not saying, "Dear madam, you have a bomb in your head," which I often have been told by the patients that I have heard before. What do I tell the people who come with a small incidental aneurysm? I tell them having a small incidental aneurysm is pretty much normal, very frequent. I cannot assure you that this aneurysm will never rupture. I tell you that the risk is very low, and I think lower than the risk of treatment. Go home, live your life, and forget your aneurysm. I believe our approach makes sense. There is probably no advantage in treatment. There is probably no advantage in follow-ups. If there is an advantage in terms of final outcome, it is so minimal that it probably represents a loss in terms of psychological and economical factors. Let's go back to what I treat. So I treat more than 10 millimeters, but also those who are symptomatic, especially the sentinel headache is a very important cause of immediate treatment of an aneurysm. It's the aneurysm who tells you, "I'm going to rupture now." And of course, sometimes when there is a strong family history. What I don't treat, less than 8 millimeter, the dolichobasilar big, huge aneurysms which have no treatment so far, and of course, when surgery is better. And there is a gray area, I must admit, 8, 9 millimeters. And in those cases, I would treat those who appear dissecting and those cases where the patients are really scared. But this is usually not a good reason to treat. But let's go to the most important message for me, which is the efficacy of treatments. So we know that we have to compare the natural history versus the risk of treatment, but we also want to know if the treatment is efficient. We have to distinct very clearly between treatment and cure. To treat means give medical care or attention to, try to heal or cure. To cure is to eliminate a disease or condition with medical treatment. In modern medicine, we treat a lot, but we don't often cure. So treatment is favorable to doctors and hospitals and clinics, but cure is favorable to patients, but not to doctors, hospitals, and clinics who lose their patients if they are cured. More important issue, the burden of proof. In medicine, it should be obligatory to prove not only the safety, but also the efficacy of any treatment. Are we sure that what we do on aneurysm lowers the occurrence of subarachnoid hemorrhage? Let's say I wake up tomorrow and affirm that if you give a patient 2 glasses of Coca-Cola, her aneurysm will not rupture. With ice in the morning, no ice in the evening. Would you believe me? Of course not. You would probably ask me for proofs. And if I tell you that your aneurysm will not rupture if you pray the flying spaghetti monster, every sunrise for 4 weeks and every sunset for 4 more weeks, would you believe me? Or would you ask me for proofs? So before talking about the risk of any treatment, one should prove that that specific treatment is useful, not just a generic religious belief. You obviously know the Russell's teapot about belief. Many Orthodox people speak as though it were the business of skeptics to disprove received dogmas rather than of dogmatists to prove them. This is, of course, a mistake. If I were to suggest that between the Earth and Mars there is a China teapot revolving about the sun in an elliptical orbit, nobody would be able to disprove my assertion. So do you believe in the revolving teapot? Are you a teapotist? I think we are all a teapotists, meaning that we do not believe in the flying teapot. But why we do not believe in the flying teapot? Because it is not in the sacred scriptures? So the conclusion is that the philosophic and practical burden of proof lies upon a person making unfalsifiable claims rather than shifting the burden of disproof to others. Prove me that treating small incidental aneurysm is an advantage to people, then and only then I will accept it. Thank you very much.